শহরের চেনা ডাক্তার পাড়ার ভিড় ছাড়িয়ে আরেকটু দূরে গড়ে উঠেছে এক প্রতিষ্ঠান যার নামেই বিশ্বাস, বেঙ্গল ফেথ হসপিটাল।
Hello, good evening and warm welcome to everybody. I am Dr.Debabrata Dutta, as a consultant neurologist, Bengal Faith Hospital. I have been given a topic regarding migraine. So migraine is a very common headache disorder. Almost every day, day-to-day practice, we encounter migraine patients very frequently, and it is a very old disorder. But today I will deliver something what is new, what is the recent advances in the diagnosis, in the pathophysiology, and in the treatment of migraine. So let's begin. In India, the 1 year prevalence of migraine is 25.2%. It is much higher than the Western population, and in migraine is the second leading cause of disability worldwide. Migraine is a very old disease. Scientifically, Hippocrates gave the first description of migraine in the year 370 BC. He described that a patient, he seemed to see something shining before him like a light. This is a aura, usually in part of the right eye. At the end of the moment, a violent pain supervened in the right temple. This is a hemicranial headache, and then in all the head and the neck, it spread over the hollow crania and the neck also, associated with vomiting. When it became possible, I was able to divert the pain and render it more moderate. So migraine is very common disease, and it's a disease of since very beginning of this civilization. So what is new in migraine? So we will discuss the new thing in the diagnosis, new thing in the pathophysiology, and new thing in the treatment. Before going to the recent advances, what is the recent scenario, current scenario of the migraine diagnosis and management in India and in the Western world? Migraine is very common. 53% of the migraineurs meet disability and frequency criteria for prevention. But the unfortunate thing is that only 5% and even less than 5% of these patients are on preventive therapy. And some of the patients are dissatisfied with the current treatment, and some of the patients having largely refractory or intolerant migraine. So, what will be the goals of migraine preventive therapy? One must restore his own function, prevent progression of chronic migraine. This is very important, and reduction of the headache frequency, severity, and intensity. So, if we don't intervene the frequent episodic migraine, if it is more than 4 or 5 days in a month, it will eventually evolve into the chronic daily headache. The patient will have headache day to day, every day, and it will be troublesome. And once from this episodic migraine to chronic migraine phase is reached, it is very difficult to treat because there are only few medicines which can handle this chronic daily headache. So it is better to intervene from the beginning, and by starting treatment from the beginning, we can reduce the cost of the therapy. We can reduce the office visit. One of the study has been published in Continuum 2015 that if we effectively treat migraine from the beginning when it is 4 5 days in a month, then the 51% reduction of the office visit, 80% reduction of the scan cost. The patient often come to us after 3 4 years that I am having a daily headache, every day headache. He visited several doctors. Whenever he visited, he had a scan, CT scan, MRI, frequent, and nothing is obvious in this scan. It was normal, all the scans. So if we correctly diagnose migraine from the early stage and we effectively treat it, we can reduce the cost, the burden of the patient effectively. Now we will discuss about the recent advances in the diagnosis of migraine. Here is the ICSD 3 classification, that is in the year 2018-19. International Headache Society give a classification of the migraine. According to this, migraine without aura, migraine with aura, chronic migraine, and there are complication of the migraine. So now the diagnostic criteria is that the 5 attacks, one must have a 5 attacks throughout his lifetime. Each attack duration to be 4 to 72 hours duration, associated with unilateral location, pulsatile quality, moderate to severe pain, and aggravation by or causing avoidance of the routine physical activity. Any two of these four, plus either he must have a nausea or vomiting, or both photophobia and phonophobia. This is the criteria for diagnosis migraine. Now we have to differentiate whether it's episodic or chronic. If it is less than 15 migraine days or headache days in a month, it is called episodic migraine. If the migraine days is more than 8 along with the more than 15 headache days in a month, so the headache patient have a headache of more than 15 days in a month, or of which the migraine days will be more than 8 in a month for 3 months, it will cause a chronic migraine. And another troublesome thing is that the medication overuse headache. This is the new term which gives an add-on to the pre-existing headache. Patient usually don't take a prophylactic medicine to treat his migraine, rather than he or she used to take symptomatic treatment, right? Like analgesics, different analgesics. In headache, and she used to go to the counter, take some analgesics. With the frequent use of this analgesic, one new headache add with the pre-existing migraine. This is called a medication overuse headache, and this is very difficult to treat. So what is medication overuse headache? If the patient is having persistent headache, who is using a single analgesic for more than 15 days in a month, or a combined analgesics or triptan for more than 10 days in a month, but his or her headache did not relieve, this is called a medication overuse headache. This is the new terminology which has been added in the classification of the ICSD 3. Next, what is new in the pathophysiology of migraine? Because if we don't know the pathophysiology, we cannot correctly intervene the treatment, intervene the pathogenesis. So all we know that the migraine is a state of vasodilatation which can causes a throbbing headache. But what is the key molecule which causes the vasodilatation? Here is the CGRP, that is the calcitonin gene related peptide, which involves in every stages of the migraine, which causes vasodilatation, which causes dural inflammation, peripheral sensitization, and pain transmissions also. So CGRP receptors occurs at all the site involved in the migraine pathogenesis. This is the key molecule in the pathogenesis of the migraine, and different studies have found that CGRP level in blood and saliva increase during the acute period. Serum levels interictally, that means in between the attack, also have been found to be elevated in chronic migraine patient, and infusion of the CGRP also evokes a migraine attack. So CGRP and the trigeminal nervous system, that is the trigeminocervical system, these two are the key factor which causes the migraine. The trigeminocervical system is the transmitting pathways, whereas the key molecule is the CGRP. So we can hit, or we can, if we can intervene in these two area, either we intervene in the trigeminocervical system so that the pain transmission have been stopped, or we give something, that is CGRP antagonist, CGRP receptor blocker, that can block the function of the CGRP so that the pain has been controlled. So now the recent thing in the treatment I will discuss regarding these two. First is the CGRP antagonist. We have been found some CGRP commercially available. There are two molecules. One is the small molecule, that are the GPANs, that is particularly used for the acute treatment of migraine, and another one is the monoclonal antibodies, that are the MABs, which have been used for the preventive treatment. Once in a month subcutaneous parenteral injection is sufficient to handle the migraine headache. So there are four MABs. We will discuss the MABs only here today because the GPANs are not still available in India. There are four maps: galcanezumab, erenumab, eptinezumab, and fremazenumab. All these have been tested in episodic and chronic migraine. All have been reported positive in their phase 2 and 3 trial, and all have a clinical meaningful responder rate. Among all these four maps, the erenumab, which is brand name is Suvire, which have been available in India since last 1.5 years. So this is the phase 3 result of the CGRP monoclonal antibodies in episodic migraine, and all the antibodies have been found to be very effective. Almost more than 50% of the patient achieved a more than 50% responder. That means that the headache days reduced to half. If somebody have a headache days of 10 to 15 per month, after using this antibody, it reduced to 5 and or even more. Uh, so this is the another study of the erenumab that has been done different parts of the world. Among India, there are 5 centers where this study have been done. One of these center was GB Pant Hospital during my DM course, and I was actively involved to this study. This was the Empower study where the erenumab have been given subcutaneously to the episodic migraine patient. Two doses, one is the 70 milligram, another one is the 140 milligram, once in a month for 3 months. And the conclusion of the result is that this study of erenumab in patients with episodic migraine from Asia, Middle East, and Latin America met all the primary and secondary endpoints. That means there is much reduction of the headache and migraine days, migraine intensity as compared to the placebo. So this is the molecule which have been used, Amovic, but Amovic is not available in India. The Indian brand name is the available here is the Suvire. And another, this is the recently published article 2022, where the calcitonin gene related targeted molecule antibodies and antagonists in migraine, current evidence and rationale. CGRP targeted monoclonal antibodies and small molecules. There are currently 4 CGRP antibodies and 3 GPANs, which have been approved by FDA for the treatment of migraine. Multiple phase 2 and 3 studies have established the efficacy and tolerability of this treatment. But one of the important drawback of this therapy is the cost. The erenumab is available in the brand name of Suvire, which has been at 20,000 per month. This is the main biggest concern. I hope in future the cost will be reduced by the pharmaceutical company so that it can be available and can be used in large scale to the large scale in the population. So what are the alternatives? Well, another alternative is that the greater occipital nerve block. Greater occipital nerve blocks target the trigeminal-cervical system. If we block the greater occipital nerve, 2 injections, if the patient is having holocranial headache or both side headache, so 2 lignocaine injections, simply 2 ml of lignocaine on each side to block the greater occipital nerve. It is found to be very effective in patients of chronic migraine where the headache frequency have been reduced dramatically. And the injection ratio, some studies have been found that they have used every 15 days interval, every 21 days interval. But what of our experience, my personal experience is that though the effectiveness of this injection persists for 3 to 4 weeks. Sometimes only single dose cannot be completely effective. In that case, we have to give every monthly or every 3 weekly injection, and the subsequent injection will give the better result, and that is a very good and the cheap which can be applied in large scale. For this, we have done a review of the role of greater occipital nerve block in headache disorders, which have been published in Neurology India, where based on the RCTs and the open label studies, good evidence of the efficacy of greater occipital nerve block was found for migraine and other headache disorder. Based on this review, we did a trial randomized control trial of migraine patient, chronic migraine patient, to see what are the response of greater occipital nerve block. We have used in this trial greater occipital nerve block as a add-on therapy to topiramate, which is a well-known drug for the chronic migraine treatment. So we selected three groups. One group has been given only topiramate, and another two group is given topiramate with add-on greater occipital nerve block. This has been published in the Cephalalgia recently, and we have found that with the addition of the greater occipital nerve block to topiramate, there was dramatic response of the headache days and the migraine days among the patients as compared to topiramate monotherapy. And based on this randomized trial, we also did another randomized trial, which is a superiority trial. We give a placebo and compare the placebo with the greater occipital nerve block in a drug naive chronic migraine patient. That means the chronic migraine patient who did not use any medication before. We have choose the patient randomized into two groups. One group have been given the placebo, another group have been given the greater occipital nerve block. This study was done in GB Pant Hospital in the year 2019 to 2021, and the first 1.5 year I was there as an active member of this study, and this will be published soon. And in this study we also found that there was dramatic response of greater occipital nerve block as compared to the placebo in chronic migraine patient. So greater occipital nerve block is a good treatment option for migraine patient who are medication refractory, who are having daily headache, who are having medication overuse headache, and the side effect is very minimal. We hardly observed any side effect with the greater occipital nerve block, and the efficacy is good, tolerability is better as compared to the other medications. So greater occipital nerve block is a good option, and the most importantly, particularly for our country, it is much cheap as compared to the other medication. So with this, I conclude and a warm wishes to everybody. Thank you very much.
বেঙ্গল ফেথ হাসপাতাল, নবাবহাট স্বাস্থ্যনগরী, বর্ধমান।